Okay, everybody, now we're going to hear Renato Vilela, Instituto Mineira da Acupuntura de Massoterapia Brasil. You can represent yourself more if you want.
All right, thank you. Hello, everybody. I'll be talking about unresolved pain. What to do? I believe everybody here had a patient who nobody ever could relieve that patient's pain. All right? The patient who feel pain for over 5 years, 10 years, it's always happening to us. So let me introduce myself. I'm graduated in physiotherapy, and I'm specialist in pain specialist, and neuroscience specialist as well. I have complementary formation in trigger points and manual therapies. It's my approach in the clinic is the manual therapies and exercise programs, like aerobic programs and strengthening conditioning programs. My two lines of work today are unresolved pain and climbing athletes' pain. So let's begin. What is pain? Pain is an individual experience. Everybody who feels pain feels something that's unpleasant, really unpleasant, and it's an experience. So when someone feels that same experience again, probably he will have more pain than the previous experience. It's a bad experience. It doesn't need to be associated with an actual tissue damage. It can be potential and can be emotional. All right? We have the classification by physiopathology and temporality. The physiopathology is nociceptive when nociceptors of our soft tissues, they start to produce informations that sensory informations that will in some point agitate the brain and then cause the pain. We have the neuropathic pain. The neuropathic pain is caused by some central or peripheral nerve injury or potential injury. We have the mixed pain. That's the combination between nociceptive and neuropathic pain. All right. In this case of mixed pain, the irritation of the nerves can be mechanical or chemical. All right. Mechanical, like James told us today, it's strains, and although seated too, like compressions from muscles, all right, and the chemical is when something alters the pH of the local, and then we have some inflammation process. And this inflammation process causes the mixed pain by neuropathic or nociceptive ways. And we have the nociplastic. The nociplastic was introduced by IASP, the International Association for the Study of Pain, in 2017. And the nociplastic pain is that pain that no exam, no MRE, no orthopedic test, no clinical tests evidence that pain. So we can see what's the reasoning of the pain. Why the pain is over there? That's no symptom or any test we can do to find that pain. It's like a ghost member pain, all right, but without the ghost member. And we have the temporality. The pain can be acute or chronic. Acute pains less than 3 months and chronic pains over 3 months. This is very important to ask the patient on the anamnesis. So we need to know what we are dealing. It's an acute pain or chronic pain, because this can change all the treatment. We have 3 not normal pain processing changes. The first one is primary hyperalgesia. Can you come over here, please? Let me take this chair. I don't think someone listened what I said. That's okay. Like, he got a upper trapezius pain, all right? So his nociceptors are all excited, right? And they start to produce some like cytokines, you know, and it sensibilizes this tissue. So I can't do any manual therapies or approach this place over here, because things that get in touch with his tissue will not resolve the pain, but instead will increase his pain. So in case of primary hyperalgesia, we need to do some other techniques like acupuncture and exercises, all right, not manual therapy over this place. And how I test the primary hyperalgesia? I will do some stimulus on his shoulder or upper trapezius that normally wouldn't make any reaction, like movement reaction or pain. So I would take like this card over here, or some cotton, okay, and I will touch his skin. If he has the primary hyperalgesia, he will make some staying really like this. He doesn't have. All right, he will do some movement, involuntary movement like this. He will shake. And then I know I need to work on the side areas instead of this local area. Because if I work in this local area, I may increase his pain. That's not cool. That's not what I want. Thank you. Wind-up mechanism, it's when the brain feels pain for so much time that even when that injury is out, that stimulus is out, the brain continues producing that same stimulus. So I've injured my hand and I've spent over 3 months feeling pain. Imagine that in the 4th month, that injury was completely healed, all right? And then I still feel the same pain, even with my soft tissue and rigid tissue healed. Why is that? Wind-up mechanism. The brain keeps producing the same pain stimulus, and we need to do some programs like physical exercises, and we need to stimulate the central nervous system as a descendant ways to cut off that stimulus. And we have the sympathetically maintained pain. This one is when my autonomic central nervous system, my sympathetic autonomic nervous system, it's so stressed, then starts to cut off or reduce the production of serotonin, melatonin, endorphins, and raises the level of cortisol in the blood. This reduces the capacity of feel pain and makes easier for someone to feel pain. So this won't hurt him. It hurts?
No.
No. But if he had the mechanism of sympathetically maintaining pain, this probably would hurt. It's like the flash pain, you know? And we have the processing of pain stimulus. That is the sensitive discrimination. It's the real perception of pain. No factors among it, just the brain processing. It's like the most pure pain processing. Affective, motivational. It's the psycho-emotional state like depression or happiness. Any of this will take in count for the processing of pain. And cognitive discrimination. That's the previous experience of the patient. He can have a good previous experience and be expecting to get healed with the treatment, or he can have a bad experience, a previous experience, and he will experience the nocebo. Nocebo is when he's already expecting to go wrong. So it's something to deal with in the clinic, and we need to talk to educate that patient about what we are going to do and how we are going to do and how can be effective. Like convince him that that therapy is good for him. We need to talk to the patient. In Brazil, I usually stay like an hour with my patients, and half of this time I spend talking with him to understand how it happened, when he started to feel pain. It's all my anamnesis at the talking. And it's very important because the patient, he can tell you rich information. So, when I evaluate that patient with unresolved pain, like, let's give an example. He is feeling a shoulder pain, okay? And I need to understand, us physiotherapists, we work with movement. So I need to know what part or in what movement, he's calling you, in what part of what movement he feels the pain. So he says to me, oh, I feel the pain in abduction. I say, okay, but when I do the movement for him, the passive movement, he doesn't feel the pain. All right, so I need to know what other movements he feels pain. And when I see external rotation or lateral rotation increases his pain. So I know lateral rotation. Let me just over here, but you are following me? Yeah? Okay. I do the internal rotation, or put your hand for your back. Okay. No pain. He doesn't feel pain in any other movements except external rotation. I know that external rotation will tensionate the internal rotators. So I'm not looking for the external but the internal, because there's no muscle activation here in the external, just the tension of the internal rotation. So I know the pectoral, subscapularis, they are muscles that I should evaluate. That's the specificity. It's the local. And when I find the local, I need to understand how how other structures, they are correlated with that pain. So I will associate with the peripheral nervous systems, central nervous systems, like does he have a wind-up mechanism, a sympathetically maintained pain? We know that the fascial system is a transmission force system, and I need to understand how the fascial layers are integrated with his shoulder. Like, I know maybe how you get injured, and he say to me, oh, I fallen and I put my hand on the ground to block the impact, all right? So he fallen just like this. I know that the reticles of the hand and elbow have a great, they are related.
Linked.
What? Sorry?
Linked.
Linked, yeah, a great link with the shoulder. So I know the first impact, the first injury was on his hand. Then I will come here and start work from the fascial system, because the myofascial cells, they instantly and uptime they start to let me see the word. It's like auto healing. They start to organize themselves, so he are able to free the movement. Like, I have several patients, they come to my office like this, and when they leave, I just work in their hands, because this place is with hyperalgesia and I can't work in the shoulder, and when they go off, they are like this, just for the hand. And I can go at the pectoralis, latissimus, obliquus, and there we go. I know that the visceral system has some, in the line of osteopathic and chiropractic as also, has some relationship with musculoskeletal disorders, like the liver can cause a pain in the upper trapezius. And then I need to check all of this to understand why my patient's feeling that pain. Because I'm now, when he comes to me or comes to you, you are his last option. He already tried everything. He's feeling pain for over 5, 10, 15 years. I have a patient that is feeling she was feeling headache for over than 50 years. 50, she was 60. She started to have headaches with 10 years old. That's a long time. And thank you. Very fine.
Yes, that's 5 minutes.
Okay. These are the 7 pathologies are the most common at my office, at my clinic. The sciatica pain is the worst. Many times, patients get there with sciatica symptoms, but not sciatica damage of the structure of the sciatic nerve. Most all the times they don't have any relationship with the sciatic nerve, because it can be a gluteus minimus trigger point that causes the same trajectory of the pain, of the sciatic pain. It goes to the ankle, it's my ankle, to the ankle, sorry, and can be the gluteus maximus pressing all the work out really hard, and when it comes, the gluteus maximus, both of them are really, really stiffy, right? And then we can use like hands prop to help us, and don't use so much strength of the hands and fingers, because you ever touch it, a gluteus maximus of a physiculturist? Yeah, it's like this. It's like doing some massage or manual therapy at a stone. And then the hands get tired. That's not right, because we need to work after that patient. And pubalgia, the pubalgia is a common symptom among soccer players, really common symptom. In Brazil, we have a lot of soccer players, so it's always in the clinic. We need to find not just the adductors of the thigh, but abdominal muscles, but we need to understand what other components are interacting with the pathology. Plantar fasciitis, like, can be the soleus muscle. It can be a internal rotation of the rib. We have so many factors that interact with these pathologies. And when we associate all these systems, like the visceral, the fascial, the skeletal, the muscle system, the neural system, we are able to understand how that pain started and who is the main cause of the pain and who interacts with that main cause, who aggravates it, what perpetuates it. And when we find it, then we can resolve that patient's pain, and he goes really happy to his home. Thank you. Any questions?
About the pain, generally. I've read someplace that it's the brain which stimulates the pain.
Yeah.
If you think through one situation, you have a little stick under your nail, it's painful and you can't think anybody else.
Yeah.
And in other situation, you have broke your arm, but you're running away, back of wolves, you don't feel pain.
Yes. It's individual, right?
Yep.
For a soccer player, small paper cut, one affects his quality of life, right? Just a small cut of paper. But for a violinist or pianist, right? A small cut of paper can reduce his capacity of work, and then it will really get his quality of life worse. So it's individual. That's why we need to do the talking and anamnesis to understand how the pain is affecting the patient, because it's one kind for everyone. It's always change. There's not a rule for it. Did I answer? Okay. Okay. Anyone else? All right.
Thank you.
Thank you. Aldo, please. For David. No, mine. Sorry.
You took yours already, didn't you?
No, mine is over there. So it's over there. I need to. It's not the recognition. It's for
Take a picture with yours. Nobody.
Yeah.
And then we terminate.
Let me just stop the
Take
video.
his camera too.
Take back this job.